Good morning and Happy New Year, everyone. Thank you for joining PHCA for today's webinar, the first one of the new year, ADL Coding Accuracy, Get the Most from Those Who Do the Most. I'm Wendy Johnson with the Pennsylvania Healthcare Association. Before we begin, I have a couple of housekeeping items to cover. PHCA offers monthly webinars to members to receive updates from department staff on regulations, learn from industry experts on current trends and practices, and to gain a better understanding of practical application tools to equip you so that you may continue to provide the highest level of quality care possible. This webinar is being recorded and will be made available on the PHCA website. The webinar has been approved for one continuing education credit for PHCA members. Credits will be uploaded to NAB within the next 2 weeks for those who have provided us with your unique NAB number. I'll be sending a link to a quick survey. Your feedback is important to us and our speaker, so please take a moment to complete the survey. All attendees will be in listen-only mode. However, throughout the presentation, please feel free to submit your questions using the questions pane on the right hand of your screen, and our presenter will address them at the end of the presentation. Now for today's webinar. This webinar is being presented by Mike Nicodemus, Director of Clinical Reimbursement with Quality Life Services. Mike will review common coding inaccuracies and the effect they have on reimbursement and quality measures, and discuss tactics to engage your staff to truly code accurately. Your learning objectives for today's webinar include identifying the most common errors in ADL coding, understanding what drives end users to code inaccurately, identifying the effects of miscoding on their reimbursement, and finally, identifying the effects of miscoding on their quality measures. I'll now turn the webinar over to Mike.
Good morning, everybody. Thanks for joining us. My name is Mike Nicodemus. I've been consulting in SNF and long-term care for over 20 years now. I haven't seen the list of attendees yet. I kind of get the feeling I probably know half of you at least anyways. Prior to that time period, I've spent my RN years on the floor and in the RNAC office. Prior to that, I started in long-term care as a certified nurse's aide. And prior to that, I was in high school. So I spent my entire professional life in long-term care. I do a lot of ADL training directly to CNAs and other direct care staff. And honestly, it's one of my favorite things to do. I really enjoy, first I pretend with the nurse aides that I don't know anything about their job as well. We're kind of getting started on the nurse aide training, and I ask them, I guess probably like the easiest job in the building, right? And I get them all fired up and angry at me. And then I'll come clean and admit that I was a nurse aide for over 5 years, and then kind of bond with them a little bit over how truly important their work is, how difficult their jobs are, and how important their documentation is. So the purpose of that is to kind of mess with the nurse aides a little bit. Is well, first and foremost, for me to have a little fun. And also that the CNA training it's two parts. It's one, it's education on words, and honestly that could take 10 minutes, and we could read off the words, define them, and we can move on with our day. But the second part is what takes a lot more time, and it's getting the buy-in. It's getting them to realize how they're telling a story of their day in that documentation that they're coding, convincing them to be honest about how much work that they actually do, how important their work is, and that their documentation is important also. So today I want to teach you a little bit about how you can do some of the same stuff with your staff. So we have our official learning objectives that Wendy just read off. I'm not going to reread them again. We are going to cover all of these areas, but I have my own little hidden agenda with our learning objectives. And that's that I want you to truly understand just how critical coding accuracy is for your facility. This getting accurate ADL coding is not a one and done venture. This is not they signed for the presentations, now everything's going to be perfect going forward, no more efforts needed sort of a project. This is an important and worthwhile priority for the health of your facility. Excellence in coding helps set, or at the very least, maintain the standard of care. So we need to make sure that we have that in our thoughts. You do it right, code it right. That's the only acceptable standard that we should allow. If we can do that, things get better in your facility. Everything gets better. So our ADL coding goals are really comes down to accuracy and consistency. We're not trying to make people always code higher. We're not trying to make them code lower. We're just trying to make them code accurately and consistent. So in that we have, oftentimes we have what we have right now, not accurate and not consistent. Nurse aide Sally codes Mr. Smith that he's totally dependent, and Nurse aide Bill says that he's limited assist, and neither of them's actually right. And sometimes we track our assessments. We're trying to monitor that ADL and code them at the highest point that we can get reimbursed the maximum rate, and that's one way to go. And yeah, it's helpful, but way easier and way more effective is to just get the coding correct in the first place. So we can also have not accurate but consistent. So, for instance, for eating, Mr. Smith's coded as independent by everybody. Everybody codes him independent. Mr. Zach, everybody codes him as dependent. We code that all the time. It's consistent, but it's incorrect. This is usually a sign that people don't understand the definitions, or they've been mistaught the definitions. We can discover this through an assessment of the facility coding to figure out where our coding is actually at, to figure out what needs changed. Our goal, accurate and consistent. Getting it right all the time, because missing either adversely affects the facility. So to get to the why are we here? Why are you doing this? Is your facility going to look different a month from now because of this hour spent? Well, first and foremost, our reimbursement. Breaking news for us. We are underfunded as an industry. I'm sure nobody's heard that before, right? At our PHCA convention in November, Vice Chair Sean Buckman gave an empowering speech on calling out our politicians to fight for our elders and for the funding necessary to provide that quality care. And it's an extremely important task that is well worth the effort. I hope it's something that we're all pursuing. Over the course of time, this can help save our industry. Another reason, though, that we're underfunded is because we underreport our care. An important step you can take today is to commit to ending this underreporting of care that is happening right now in your facility. This is a step that will give a return on investment as soon as next month. It takes a commitment and not a single training presentation. So, inaccurate coding negatively affecting your reimbursement. What else? Our quality measures. ADLs directly drive 3 of the quality measures that create your QM score. Inaccurate coding is the principal offender in substandard scores in all 3 of these. ADL declines, mobility decline, and then functional improvement. So to get a little bit into the defining of these things, what is accurate? What exactly are we looking for as far as accurate goes? Well, first off, we need to make sure that we're comparing your residents to yourself, not to other residents. Caregivers have difficult, demanding patients to take care of, so they tend to appreciate those residents who can do some things for themselves. And they tend to give them a little bit too much credit for how much they're actually doing. I've watched a tray be given to a resident, everything open and prepared, and the resident doesn't start eating. The aide comes back around, puts a bite of potatoes into the resident's mouth and kind of gets them started. The resident kind of triggers them to start eating, and they eat the rest of the meal independently. And then we code supervision. So we have a little discussion about that, and I asked, I seen that you coded supervision for that resident. Yeah, I made sure she ate. Well, I saw you put a bite of food in her mouth, though. So just one bite. She's independent, though. I barely even helped. I just give her one bite, and then she got started and ate everything on her own. I thought, well, think about that, though. You're actually feeding a person, and you're not really taking any credit for that. So let's take the nursing home location out of this discussion, and say you're in a restaurant. And I'm not sure what kind of fancy places you like to eat, but I'm never at Wendy's. And Dave comes around and says, hey, come on, Mike, let's get going here, and starts putting French fries in my mouth. And to be fair, I would eat the rest of the meal independently and probably rather quickly to make sure that doesn't happen again. But I think most of us would be a little put off by that. You know, like if the waiter came by and put a glass of water in your hand and says, hey, come on, let's go, let's keep it moving. But, you know, in long-term care, we report over and over and over again that that's independent, that's supervision. So we need to make sure we're asking questions. You know, why is the resident here? Is feeding a person who's sitting there, is that normal restaurant behaviors? Taking the facility out of the equation and really looking at it as in a bigger picture. So nurse aid documentation is different than MDS documentation. We have to really consider, on the MDS, we're coding for a 7-day period always. With nurse aid documentation, it's windows of time. So if nurse aid coding for the event that just occurred, the rules are a little different than if they're coding for the entire shift or for the entire meal. Each event that they're documenting on has to be coded based on how much time period is being covered. That has to be part of the training that they understand it. So they could be coding transfers in the morning and the resident was contact guard limited assist. In the afternoon, they required weight-bearing assist. We can code again if we have that ability for electronic records. We can code again for the different time period. And it's hard sometimes to get the CNAs to accept that they can code more than one time per shift without making a correction. Now, if we're still on paper documentation, that's a different situation where you would have to make a correction to alter that documentation. Coding is interpreted based on a set standard. So we're transmitting this information and it's going to be interpreted based on some specific rules. Looking at those rules, bed mobility transfer and toilet use, I want to pull these out separately. Nurse aides code the highest level of support they gave over their shift or per the event coded. So if they, for the time period that they're coding, they were independent, no help, no oversight was provided. So this would be somebody getting ready to go home. Yes, we have independent patients in our buildings. Supervision, oversight, or cueing provided, no touching. So up until this point, we could build ourselves a little wall here, and we could be on the other side of it. Drop the end there. And we could provide independent supervision from behind this wall because we don't physically have to be present to do it. Once we're physically present to do it, it's limited assist at least. We could be guiding, but we're providing no weight support at all. None. And this is a very difficult one, again, with the nurse aides to understand. Anytime we start to take on any weight, whether it's helping them to transfer and lift them a little bit, or once they do transfer and they stand up and they're a little bit unsteady and we have to kind of help stabilize them from left to right, that's also taking on weight support. So that all counts. We'll make sure that we're considering those things. Once we take on any weight support, it becomes extensive and it stays that way until we take on all of their weight. So up to through 99.999%, you have to go get your friend and your friend helps you stand somebody up, but the patient still puts a little weight down on their feet and they help transfer. They're extensive of two-person support. They stay that way until they don't do anything for themselves. So we can get into danger here. When you say total dependence, total does not leave you a lot of wiggle room. If you say a resident is totally dependent, they didn't assist in the activity over the entire time period that this entry covers. So if you pull a resident up in bed and code for just that one moment and the patient didn't help at all, you could code total dependence. But if you're coding for your entire shift, and in between those times where you pull the resident up in bed, they're rolling themselves back and forth, they're turning and repositioning, you would code extensive. You wouldn't want to code total in that situation because it would be inaccurate. You'd only code once a shift if the activity did not occur. If these things did not occur over the entire time period, generally speaking, the entire shift, we would code activity did not occur. We need to make sure our staff knows that anytime their friend here has to come help them at any part of the activity, they need to make sure that they include them in that activity as well. So otherwise, the facility doesn't get paid for it, and then we don't have money to pay them either, right? And that does not make anybody happy. So for eating, same idea here. If we're coding for the time of the event, is this just for the meal? Is it for the entire shift? We code twice a day. They need to understand they're coding for the entire time period that they're coding for. So Independent, no help or oversight. Supervision, cueing, monitoring, no hands-on. Again, same wall, same position. We can provide these things from across the room, from behind a partition, no physical contact. Limited assist. Once we start handing them silverware, handing them cups, helping to guide their hands, but we don't feed them at all. So the far as you can take limited assist is that resident who's feeding himself, but they're coming in a little bit wide with that spoon, and we just kind of help them aim it in a little bit towards their mouth. That's still limited assist. But once we take any of the weight of that spoon or the entire spoon, or we put a straw in their mouth, we put the drink to their lips, when we're putting nourishment into them, it becomes extensive assist. It stays that way until the resident doesn't do anything for the entire time period that we're coding for. So if we're coding once a shift and we fed the resident their meals entirely, we fed them all their snacks entirely, they never lifted a finger, but then they get into their neighbor's candy dish and help themselves to some M&Ms, they're extensive. They fed themselves some. So we want to make sure that we're actually being completely accurate, and we want to be consistent with how we're defining these. This question comes up very regularly in our trainings. Are any of our long-term residents ever independent, specifically in eating? And absolutely yes. Residents are considered independent in eating. General supervision of the dining room, general supervision of the residents in the building is not considered supervision for eating. So the REI provides an example of what is independent for eating. So in this case, the resident consumes all their food and fluids without any cueing or physical help, and they're coded as independent. Defining supervision, which is where we're providing verbal cues to the resident to eat slowly and drink throughout the meal, in which case they would provide supervision. So especially when we're considering residents who are getting ready to discharge, we want to be able to code independence, for especially looking at transfers for your QMs, that these residents should be getting independent. That's the direction we should be going. If they're getting ready to discharge home to live independently, we should be getting them to that point on the days leading up to their discharge and make sure that they can do it safely. So our interpretation of this information, how we interpret the meanings, is irrelevant. We have to make sure that we're defining these the same way as they're being interpreted. We transmit this, they decode. They decode this information based on these specific definitions. Any misinterpretation is caused on our end, on the coding end, not on the interpretation end. It's up to the facilities to make sure that we're transmitting the appropriate information based on the defined meaning. So some common errors. Bed mobility coded as total dependence. Like I mentioned before, if that resident's able to turn and reposition themselves in between when we're doing the total effort of lifting them up, we need to make sure we code that correctly as extensive. Because if we code it as total dependence, even though they turn and reposition on their own, at some point along the line, if they happen to develop a pressure ulcer, and we, of course, you're defending this in court later, say no, they've moved themselves in bed. That's why we didn't have them on turning and reposition program. They're going to pull that documentation and say, no, you coded for that entire time period. They were total dependents. Why weren't you having them on a turning and reposition program? So we want to make sure that we're being accurate in what we're coding here. Transfers and toilet use coded as limited assist when weight bearing was utilized. I have gone round and round so many times with so many nurse aides on, I watch them transfer a patient up. The patient can almost stand up on their own, but they just have to give them that little boost up out of the chair, and then the resident walks on down the hall and they're marking supervision, independent, limited assist. And I can show them the definition and explain it to them, and it's just so hard for them to accept that that was extensive. That's an extensive amount of support anytime we take on weight bearing. We undercode eating a lot, especially when we're given reminders, when we're handing them cups. So looking at 3 to 11 and 11 to 7, first off, we should be coding on eating documentation on 3 to 11 and 11 to 7. Usually 3 to 11 is, sometimes 11 to 7 is not. but we pull that resident up in bed. They want a drink, we hand it to them, we put the cup in their mouth, but we still end up coding supervision, limited assist. I mean, if we're handing it to them, it's limited. If we're putting that straw in their mouth, that cup to their lips, we should be coding extensive. And we miss out on a lot of revenue on that one particular area. We tend to really undercode that. Feeding that first bite to an otherwise independent resident, we always call these kind of our kickstart residents. You give them that first little bite and then they're good to go, but we often forget about it. We need to make sure that we're taking that into consideration. So again, you know, that fancy French waiter of yours shoving a croissant in your mouth, would that be considered a normal thing or not? It would be extensively odd if someone fed me in a restaurant. So I try to keep that in mind when I'm trying to go over the nurse aid documentation with them. So our quality measures directly impacted. ADL decline on the long stay, move independently worsened on the long stay, improvement in function on the short stay. There's a lot of points on the line here, and these are easy ones. So every one of these QMs ranges from 100 to 20 points. So there's an 80-point swing. There's 3 of them. That's 240 points. And I always say these are 240 give-me points for accuracy. It isn't like with falls with major injury where, you know, a fairly independent resident maybe leans too far out of their bed and falls on the floor and has a hairline fracture of a finger, and we have to call that a fall with major injury, and there was nothing really we could have done to prevent it, and then it stays with us for over a year. The biggest impact to these quality measures is just inaccurate coding, and we can look through these and get some examples of how that is. So ADL decline, we're looking at your target assessment compared to the prior. This is change in 2 points of one item or change in 1 point of 2 or more items. So this is not a cumulative total, and that's important because you could have bed mobility and transfer improve and toilet use and eating both decline. That's a decline. Then the next quarter, these 2 improve and bed mobility and transfer decline, again, a decline. And then again, the following quarter, they revert. You could have a patient show a decline in this every quarter for 20 straight years. Unfortunately, that's the way it works against us. And what's it all driven by? Consistency. Now, you know, I hear oftentimes, but we're long-term care. We're going to have decline. And of course, we are. We're going to show decline. I mean, a lot of our patients are here through the end of their life. So they're probably going to show some decline over time. But keeping in mind, this is just target compared to prior, and we're allowed a 10% cushion for that. You can have 10% of your patients every quarter show a decline in ADLs and still get your full 100 points. That's probably pretty generous, honestly. I mean, you can even go 13 and still get 80 points. So we give a ton of points in these categories because we're not consistent. Move independently worsen. So again, target compared to prior, locomotion on unit, self-performance, decline of 1 or more points. Most of our residents in long-term care should be pretty consistent in this, if you think about it. I mean, when you think about your patients who kind of tool around on their own out there a little bit, maybe they do some on their own, they need some help, or some of them just kind of, completely independent. They're usually that way for a pretty long time. And we have some cushion here for some decline. We're expected to have some in our industry. Where we really get hung up again, though, is the consistency. So if we have a resident that you're coding as dependent on the prior assessment, if they're dependent, they're excluded from the denominator. So now you can't even get to count them as maintaining. So if they go from dependent and improve to extensive, well, they still count against you because they don't count in your denominator, so they're basically working against you. And then the next quarter, they improve from dependent to extensive. Well, they don't count because they were dependent on the previous. And then they go from extensive down to dependent. Well, now they count as a decline, and so on and so forth. So each quarter, they can either be not even counting as a maintaining somebody's level of independence because they're excluded from the measure. They could and every other quarter counting against you as a decline. Again, if we could just be consistent, if we can get accuracy, consistency, we beat this problem. Okay, functional improvement. This is on our short stay on all payers. We have so many of these anymore. I try to make sure that we're reminding people. In this particular one, it's all payers are included. We're looking for a successful improvement of 1 point combined total between transfer, walk-in corridor, and locomotion on unit. So 7s and 8s, the only happened once or twice or did not occur, count as 4s, you transfer them over, and we're looking for 1 total point of improvement. Now, there are some true barriers to this measure. Some patients make gains, but they don't leave the categories. You could have a resident who comes in, extensive assist of 2 people. You're doing 99% of their transfer for them, so they're barely helping, but they're still extensive. And then when they leave to go home, they can almost get out of the chair themselves. Just give them that little boost, so they're extensive of 1. That doesn't count as an improvement in transfer. But you'll probably still make some improvement in walk-in corridor or locomotion on unit. Some residents may be discharged to hospice. If they weren't hospice when they came in the door, they're still going to count. But maybe along the course of their stay, we decided that they're just not going to make improvement, and they decide that they want to go home and spend the remaining days in their own private residence under hospice services. Well, that person is still going to count to your measure as a discharge return not anticipated. And it's reasonable that you might not have made improvements. And maybe they discharged to another skilled nursing facility. Again, though, you would have time to make some improvements before they do that, but maybe they discharged fairly early and you didn't have a chance yet. Finally, sometimes there's a very short time between the first assessment, the 5-day admission, and the discharge. Maybe your 5-day was done on day 8 and they discharged on day 9, leaving you only 1 day to make any additional improvements, and 6 of your 7-day lookbacks are the same day, so you might not show it there. However, again, we got baked into this equation a nearly 20% cushion for those sort of situations, which should really be the exception and not the norm. And even beyond that, we've got a 29% cushion to get you at least 80 points in this category. That leaves a lot of patients who are leaving for other reasons and not making improvements. So, excluding these few patients, we have a 20% cushion, and all we're trying to show is 1 point of improvement for patients who came into our facility when they were too sick to go home, and now they're going home. So we really should be able to get all those points as well. And where I really see the loss is just in poor documentation. We get used to coding and don't change. So in our reimbursement side, ADLs drive all of our reimbursement. ADLs are the greatest source of coding loss related to revenue loss. They affect every RUG category. I've asked people before, if you could make $5,000 a month more for your facility, if you could get your ADL coding correct, would you do it? And everybody's answer automatically, absolutely, we could use it. We need every penny we can get. The truth is, every one of these items, individual items that we're going to look at, any one of these can mean $3,000 in one patient's Medicare payments for 1 month. Any one of these can mean $9,000 in quarterly Medicaid rates. And I've seen it occur over and over again, where one instance of weight-bearing assistance makes that difference. One bite of food fed, one drink placed in a hand on 3 to 11 or on 11 to 7, a straw brought to the lips during midnight change, one instance of a caregiver support, a second person coming in to assist in a transfer. Getting that coded makes all these difference. And I've also seen where one instance of overcoding total dependence has cost a facility this kind of money. Where a resident was maybe coded 15 different instances where they were limited assist, 2 instances of extensive, and 2 instances of dependent. Well, any one of those instances of dependent with a resident who's that independent probably wasn't accurate. We probably overcoded dependent. Dropping that down to extensive where it should have been would have increased the score and got the facility paid significantly more money. So any one of these can mean that much, and it could be happening right now out there on your units. Some other impacts of ADL coding, of course, your PVJ staffing requirements, whether you're overcoding and driving up your staffing requirements, negatively affecting your staffing scores, or under-reporting and not having enough staff. Covariates and exclusions for your quality measures and some of your quality reporting programs. Short stays improve mobility and pressure ulcers. Long stays, pressure ulcers and decline in locomotion. It's too much to try to chase all these individually for every resident and try to follow and compare to your measures. But if you are accurate in your coding, then the assigning scores will help make those covariates coded properly, and you'll be getting the proper scores that you deserve. So, the cause of our errors. Hurrying, number one. And I don't know how many of you get my reference here with the woodpecker in the tree. As many people are converting over to electronic health records, and we put these kiosks up in the hallways, the first thing that people notice is that about 2:30, it sounds like a flock of woodpeckers move in every day, because all you hear in the hallways is a bunch of, and it comes down from them tapping as fast as they can pick an answer as those questions appear on their screens. And it's because they've got a lot of work to do. They have a lot to try to get done, and they see that clock ticking, and they're running out of time, and they want to get it finished. We want them to be able to actually read the questions and provide thoughtful answers, not just the first thought that comes to their mind the moment that screen pops up with a possible answer. In line with the hurrying, the second aspect of it, getting used to coding a resident and never changing it. And this is really where we see that in that functional improvement. Residents come in, extensive 2 people, they leave, extensive 1 person, or extensive 2 people still, and they walk out. They come in on a stretcher and they walk out the door, and it looks like we've made no progress. But you know what happens? They see that name pop up. Smith, I know him. He's extensive. Tap, 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 and we're done. Well, he was, but he's being discharged tomorrow, and he just walked past you. So, maybe we need to slow down and think a little bit that he's made some changes along the way. But every day for the last 2-3 weeks, they got used to coding extensive, so that's the button they hit the minute it pops up, because they're in a hurry, because they have lots and lots of work to do. The names. Limited means a little, extensive means a lot. I hear this from them so many times, and all of us in the nurse aides always make, the RNACs always make the same face when these words are stated. We have to continuously work on stopping this. That's not what those words mean. We've got to make sure that they understand that that's not true. And this is the one that probably hurts the most. It hits me a little bit right in the heart, because the nurse aides don't care. Well, okay, if that's true, then why don't they care? So I'm providing you here with an artist rendering of where our nurse aides believe their documentation goes. They fill it out, and it's gone forever. I've actually heard them say that. Because we have to put something down, it doesn't matter what, or we put it on there and it's gone forever. No one ever looks at it again anyway. So if it's true that they don't care about their documentation, have we caused it, and have we worked to prevent it? What have we done to make sure that they understand that what they're doing is important, but also that what they're documenting on is important? So what can we do to get some accuracy? So for the first problem, hurrying, can we free up some of their time? Only have your aides document on what you actually need. My assessments on documentation routinely turn up tons of things that we ask the nurse aides to document on that are really unnecessary. And a lot of times it's because maybe a family complaint or something along the lines of family says that Mr. Smith's not getting shaved, so we're going to make the aides document that they shaved him. Well, if you look at his face and it's all woolly, are we going to go to the family and go, oh, look, we signed for it, it's good? You're imagining that. Or if he's smooth, do we need them to document that it was done? It's self-evident. So keeping that in mind, what's the purpose of the things we're asking them to document on? If we can get rid of even a few of them, you give them a little more time to be productive. Problem, getting used to coding a resident and never changing it. We need to make sure we're discussing changes, especially planned discharges. Make sure the aides know that patients are supposed to be doing more on their own relating to pending discharge, that they're doing that. So again, it's not just coding right, doing it right, coding it right. So we discuss in our stand-up meetings every day that, how so-and-so is going home this Friday. What are we doing with that information? Are we taking that back to the units and having a huddle and making sure that the aides know, hey, make sure you're reinforcing this patient's going home on their own. Have them transfer themselves, contact guard, be there for them, make sure they're doing it safe, but they need to be strengthening themselves and adding to what therapy does. They need to understand that they're an important part of the discharge team. This really goes hand in hand with PDPM that's coming here in October. We're going to be getting measured on how much improvement these residents make. And, in our training currently with PDPM, we're trying to reinforce the idea of discussing with CNAs being part of the discharge plan, that they're helping to implement that. They're helping to supplement what therapy is doing and working on getting stronger. And so we can have more successful discharges. Patients go home stronger. They have a better chance of not ending up back in the hospital. It's good for them, good for us, good for everybody. So we want to make sure that we're really promoting that. Oh, the misleading names. Limited means a little, extensive means a lot. Truth is, limited means contact, but no lifting. Extensive means any weight. We have to continuously educate on this. Make sure that they understand the interpretation of what they are recording. When they're coding something, it's not based on what they think it means. It's based on what the person reviewing their answer thinks it means. So they need to understand that that person at the other end of that black hole is getting that information out there at CMS. They think when they say limited, it means that they did not lift at all. That patient's basically doing it all by themselves. We're just there to help kind of guide them. Just stop them in the hall, ask them to tell you what the definitions mean. It has to be a continuous, endless cycle to get them to know what those mean and to make sure that it's right into their heads that no, limited does not mean a little. Limited means contact, no lifting. Make sure they know what their documentation means to staffing, that it affects how we staff the facilities. That their documentation is very important in how we make those choices and how much help they get. So what do we do about apathy? Well, the very first step in making sure that the documentation is recorded with some belief that it's going to be read is in reading their documentation. Very important to do this. You've got to make sure that we are actually reading this information. That will help make sure that we're commenting on it. So comment on it. Make sure they know that we're looking at it. When I was going back to when I was a nurse aide, we still had flip books. We had the everything on paper, and it was a curious thing that happened, but from month to month. Patients who were limited assist all of September suddenly became expensive in October. And then maybe in November they would become independent or dependent. It was funny though, all the changes happened between the months, and throughout the months everything stayed exactly the same. Right now we have the flocks of woodpeckers and they're tapping away at our screens. Back then we had parrots, where we all just repeated whatever the person before us wrote. And to make a point of this one time, I decided it might be fun. For bed mobility, I recorded G and F for self-performance and support. And then I did the same thing for transfers and toilet use, etc. And, lo and behold, the patient became G and F for the rest of the month, which I found to be very humorous. However, what I learned was people do actually read that documentation, namely my RNAC. My RNAC did not find my little fun game to be at all humorous, and neither did my director of nursing or my administrator, and I got wrote up for it, and I didn't find any of that to be humorous myself. However, what we did learn from it, we learned that sometimes they will ask about it. And they asked, do you guys copy your documentation? No. Then why did everything become G and Fs? Good and fair? So we all learned a valuable lesson in me about that actually people do read my documentation. So make sure I didn't do that again. Make sure that they know that their documentation really matters. The work that they do really matters. They provide so many valuable services, and we need to make sure that they're documenting those things that they really do. And if you want somebody to do something for you and then they do it for you, what do we always do? We'll make sure we thank them for it. You know, the number one desire for people to work to feel that they enjoy their jobs and they like where they be is to be appreciated. And if you think about your best days, it's not, you know, it's not payday. It's not the day maybe you snuck out 5 minutes early. Your best days are really the days that somebody comes up to you and really appreciates the work that you do. Whether it's a family member coming up and saying, hey, you know, thank you for the care you provided Dad here. It really means the world to us. Or if it's your boss coming to you and saying, I'm really glad I have you. You know, you really make my days better. That's the stuff that makes people come back to work and want to do a good job. So you don't hold that back. Every chance you get where they've done something for you that they've done a good job, make sure you're thanking them for it. And maybe something more tangible you can do. You know, you can give badges to good coders as coding mentors. It doesn't have to cost you a thing. That it does two things for you. It provides a resource for your other nurse aides. Like, oh, I know who. I'll go ask Margie about my documentation. Or she's a good coder. I can check with her and see what I should code in this situation. And second, it shows some value and appreciation to those people who do your best coding, who are your most accurate coders. So those are all some real good things you can do to help get your nurse aides to really care and to really code properly. So the next thing we can do is you got to be able to monitor to figure out if you're making any improvements. You know, if you're wanting to know how far you traveled, you don't get out a map and say, you know, where do we start? I don't know. Where are we going? Not sure. How far is it? 8 miles. All right. You know, you got to have some idea of where you're starting and where you want to get to. So when I do the ADL training, we always do a measure of total change. So we'll start out, I'll measure the ADLs for 2 weeks where we have electronic records where we can do such a measurement. And then I'll skip the couple of days during the training and then 2 weeks following and compare the differences. So in this particular facility example, you know, we went up quite a bit in independent and eating. We went up 3%. Independent went down in transfers and in toilet use. Supervision went down across the board. Limited assist went down across the board. I mean, especially toilet use. We went down 5% in how many people were limited assist for toilet use. Extensive, we went up quite a few areas. And in this facility, which is kind of unusual, frankly, is we actually went up in some areas of total dependence, everything except for eating. We actually increased in. Now, more common, this will be a little more as a common response I get from a facility. Went down a little bit in independent, went up mostly in supervision, actually went down a little bit in eating under supervision. But limited assist, we went up quite a bit, 3% increase in limited assist for eating. So we're starting to capture some of that 3 to 11 and 11 to 7 stuff properly. We went up in extensive in eating, probably capturing some of those residents where we give them a bite of food and they get started. And every other category went up in extensive. Bed mobility, transfer, toilet use, everything went up in extensive. And we went down in total dependent. And the one I usually look for in this one is only 1%, but I look for that bed mobility to go down. Sometimes we overcode that. We don't take credit for the resident moving themselves. And if they're not moving themselves, we should have them on a turning and repositioning program, which we oftentimes don't if they are actually repositioning independently. So make sure that we're actually including all those sort of things. So some final thoughts: set coding edits in your electronic health record if you have that ability. Be careful with those. Sometimes they'll actually cause miscoding. If a resident's asked to code for 2 people or to double check even a warning if they're coding expense, sometimes they'll just change it and code it down to limited assist instead. You know, you want to make sure that you're not discouraging them from coding accurately. If you have questions set up where that disables future questions if they code a certain way, you can bet your dollar that they'll find those shortcuts and they'll tend to code towards the questions that eliminate other questions. So you want to make sure you're setting your EHR up in a way that doesn't discourage accuracy. Make sure they're actually doing things right so they can code it right. So especially like with discharge plans, If they're not aware that this patient should be doing more things on their own, then maybe they're not just not coding it right, maybe they're not doing it right in the first place. So we will make sure that they're doing it right first and then coding it right as a follow-up. Rounds and pairs, another great way to make them do it right. This is specific mostly to like our sleep time, late 3 to 11, 11 to 7. And I've been told by every facility I think ever involved with this that we can't do rounds and pairs because somebody has to answer the lights. Well, honestly, whenever people are on different hallways working, is one person standing out in the hallway watching the lights while the other person's in a room? No, everybody's just doing their own thing. So we can always do rounds and pairs, and yes, nurses can answer lights. I was able to answer a light as a nurse on midnight. It's not that hard. So we really should be able to do that. You know, and it's funny, one of the facilities that I was giving my ADL training to was a facility I worked in previously. And I'm speaking to 11 to 7, and I'm talking about, you know, it's important to do rounds and pairs. And one of the girls I used to work with said, we can't do rounds and pairs. We can't do it because, you know, somebody has to watch the lights, et cetera, all the excuses I always hear. And I said, but, you know, Barb, you and I, when we worked midnight together, we always worked in pairs. And she paused for a moment and said, well, that was different. I liked working with you. And I think a lot of times that's what it comes down to is sometimes our 11 to 7 crew, some of them are, maybe they're loners and they just don't want to work with other people. But if you work in pairs, one, you're not tempted to pull that person up in bed by yourself when you shouldn't. Two, if you do have to go get somebody else's help, you spend more time going and try to find that other person. By the time you come back, the resident already fell back asleep. Now you're waking them up and disturbing them again to pull them up in bed. Three, if the patients are independent enough, you can work. One person can take care of one, you know, person in one bed while the other one's on the other bed. I mean, you don't have to be hand in hand the whole time. And then finally, not to mention just, you know, the boogeyman factor in the, you know, 11 to 7 shift in the nursing home. Things are a little spooky. I always liked having a friend with me anyway, so it's a great way to go. It really helps discourage from people trying to do things by themselves. So do it right first, then you can code it right. Provide engaging education that allows beliefs to be challenged. Now, that doesn't mean that we can deviate from what the rules are. I mean, the definitions are still the definitions, but we can have some engaging education. We can talk. We can have a discussion. You know, it doesn't have to be an argument. It can be where beliefs are challenged, and if you can get past that, you can get people to understand and believe what's really true about this documentation. We've got to watch out for those mad woodpeckers working those kiosks. I mean, you got to shut that down. We need thoughtful and truthful answers when we're answering those questions. If you don't have that, you're not going to have any accuracy and no consistency. Set a repeating schedule of training and evaluations. If you don't come back to this, if you do it once, you will regress. It happens all the time. If it's not on the forefront of what's important to the organization, it goes away, you know, with anything. Different voices with the same message. If just the same person's telling the nurse aides the same thing over and over again, over time it just becomes background noise and they don't hear it any longer. But when different voices bring the same message over and over again, it really helps a lot in making that message land home and be believable. We got to make them want to. If they believe that this is helpful to them, to their facility, to their residents, if they can be part of the change that they want to see in the building and make the facility they work at a better place, it'll help them want to do it. And again, if we're accurate and consistent, it'll make everything in that facility a little bit better. Any motivation always starts with an expectation of results. You know, what is our expectation? We're looking for accuracy. We're looking for consistency. We want to make sure that we say that word accuracy a lot. We don't want them to think that we're just trying to cheat or we're trying to get them to code a certain way. We're just trying to get to a level of accuracy. And if we can maybe set, what is that expectation? We set that expectation, and if that's that our quality measures are going to improve or that our reimbursement is going to improve because of this, let's set a goal to it and a fun reward, whether that be a pizza party or, you know, ice cream or whatever, you know, your staff might like. Maybe take them out for cocktails afterwards. Let me know if you're doing that. I'll be happy to join in. Make it a fun time, whatever your staff particularly like, but make it something that they actually appreciate. You know, the first step to any program is just getting started. If you can find one thing to start working on, whether it's one nurse aide, one wing, something that we can start working on, making some progress on, it's a start. And then just keep building on it. Measure your coding before and after the training event so you can validate if it's been effective. You do a training and did it make any difference at all? Did anybody change? And then you can start looking into, well, maybe wing by wing we can look at. Did South Wing did it, but North Wing didn't? You know, we can start looking in a little bit more detail of where our ongoing opportunities are. So our next steps, first, evaluate where you're at. Like I said, you're figuring out how far you want to travel, you got to figure out where you're at on the map first, right? So evaluate where you're at, schedule an education event, get that coding measured prior to the educational event, educate, get everybody trained at one time, and then measure the coding afterwards. And then continuously evaluate for ongoing opportunities of improvement and repeat. Well, I know this is riveting stuff, and no one's here just for their administrator CEOs. So if we have any questions.
Great. Thanks, Mike. That was great information that you shared with us today. At this time, we will open up the question and answer portion. So if you do have any questions, type them in and we'll have Mike answer them. Don't forget to check out our upcoming 2019 webinar offerings. The schedule is still coming together for the new year, so we will have a lot more coming your way in the new year, so keep an eye out for that. And we do have our ALPC Summit coming up in March 21st here in the Harrisburg area. So we do have a buy one, get one opportunity through the end of next week. So if you or anybody that you know would benefit from that educational offering, there are 6 CEUs offered, and we think we have a really good agenda for that day. So if you or anyone you know would benefit from that, it is a great money-saving opportunity with the buy one, get one that expires January 18th. So about another week or so to sign up for that at the reduced rate. All right, Mike, you must have done a really great job covering everything because we don't have any questions. Oh, we do have a question. I spoke too soon. Here's the question. How often do you recommend training? Would you do ongoing training with one ADL a month?
Well, because all of the ADLs are so similar in how they're coding, we would typically do them all together as opposed to one ADL a month. But what you might do is, again, so sometimes we'll start off, maybe we could do monthly until we kind of get a handle on it, and then you could maybe go to quarterly. But it would basically be based on the evaluation of your facility. So see how the training's going. Keep monitoring it. Keep an eye on how your coding is going. If you hire a bunch of new aides, obviously we want to restart with them. Maybe you do a wing a month would be more convenient for you than trying to do one single ADL for everybody a month.
Great, good question. Any other questions before we wrap it up? We have a couple more minutes, but want to give you, your time back in your day if we don't have any more questions, and know that Mike's contact information is here. I will also share it in the follow-up email that you'll see later today. All right, I think we're good. Thanks again, everybody. Don't forget to complete the survey, and we just want to thank Mike for presenting on this topic. Hopefully we'll see him again, maybe later this year at the annual convention, so look for that. And I just want to wish everybody a great remainder to your day and your week.
Great. Thank you, everybody. Have a great day.